Right. We okay to start?
Yes, sir.
Right. Hi. Good afternoon, everyone. Thank you very much. Thank you very much for inviting me to give this talk, Paclitaxel versus Sirolimus. My name is Edward Chok. I'm a vascular surgeon at Northern Heart Hospital, Penang, and before that, I was in Singapore. So we'll go straight into it. There are two choices for drug-coated balloons in the market for treating peripheral arterial disease at the moment: paclitaxel-coated balloon and sirolimus-coated balloon. Now, obviously, paclitaxel-coated balloon has been around longer, so I'm going to go into the data surrounding both these drug-coated balloons. And when we talk about drug-coated balloons, we need to talk about above the knee and also below the knee separately. And for me, we need to consider the efficacy versus the safety of these drug-coated balloons. So let's move on to talk about paclitaxel-coated balloons for above the knee. Now, this has been around for a long time now, and so we know that in terms of efficacy, there is no doubt that paclitaxel-coated balloon is superior to POBA. However, in 2018, safety concerns were raised, and this was quite controversial. And since then, there have been new data to demonstrate no safety concerns with paclitaxel-coated balloons. So there are multiple level 1 evidence for PCBs for above the knee SFA. All these are randomized, multi-center, blinded, core lab controlled, and CRO controlled trials which have shown that paclitaxel coated balloon is superior to POBA for above the knee. And this is the summary of some of the major RCTs. The Lutonix RCT showed superior 1-year primary patency for paclitaxel coated balloon, and so did the Ranger SFA and the Impact SFA studies as well. So then, why do we need alternatives to paclitaxel if paclitaxel is so superior? One of the first concerns was published in 2018 by the Katsanos meta-analysis, which showed that at 2 years, there was, according to their data, a 68% relative risk increase of all-cause death. And at 5 years, the numbers were even worse with a 93% relative risk increases. This has, as you know, caused quite a lot of controversy at the time, and since then, multiple other investigators have also shown through their other RCTs that this was in fact not their experience with the use of paclitaxel-coated balloon. This was one of the trials called the Sweet VAS trial published in New England Journal of Medicine, which showed that there was no increase in mortality with paclitaxel-coated devices. And similarly, when the German investigators looked at their own healthcare, they looked at all their 9.2 million insured people, and they showed that neither DCB or drug-eluting stents with paclitaxel was associated with any increased long-term mortality. What about paclitaxel for BTK? This, for me, is the greater concern with the use of paclitaxel-coated balloons. As you know, there are multiple challenges with below the knee arteries. These are very challenging arteries. These are small, frequently calcified with long CTOs, and there is a real risk of thrombosis with distal embolization leading to acute limb ischemia. All of these will lead to poorer patency with high rates of recurrent disease and high rates of reintervention in general for below the knee arteries. So let's look at the data available for paclitaxel-coated balloon and below the knee. Now, I think it would be fair for all of us to say that for paclitaxel-coated balloon, they are very good for above the knee, but for BTK, they have shown equivocal results. And in fact, it is also high concerns with amputation rates with paclitaxel-coated balloons when these are used for CLTR patients in below the knee. So there have been multiple negative paclitaxel-coated balloon trials for BTK, and some of these are Impact Deep and the Singapacli trial. The Singapacli is our own trial for Singapore. The Impact Deep trial was one of the earliest trials on the use of paclitaxel-coated balloons for BTK. This was a large trial of about 358 patients, 2-to-1 randomization of 239 paclitaxel versus 119 POBA. Follow-up was with 5 years. This was using the Medtronic Impact Amphiron paclitaxel-coated balloon. And this was the key 12 months efficacy endpoint. And they showed that there was actually no difference in efficacy endpoint between paclitaxel and POBA for BTK. Now, what is more worrying from this trial is that they showed that amputation rates at 12 months was higher if you use paclitaxel-coated balloons. 20 in the paclitaxel-coated balloon group versus 4. And this resulted in Medtronic recalling the use of their Impact Amphiron paclitaxel-coated balloon for below-the-knee disease based on these trial results. This was our own trial, single Pacli trial, which was published quite recently. A smaller trial, 138 patients, one-to-one randomization of paclitaxel versus POBA using the Biotronic Pasio 18 Lux paclitaxel-coated balloon. And this was the key results. At 6 months, primary patency was no difference between the paclitaxel-coated balloon group versus the POBA group. And amputation at 12 months was also statistically no difference, but numerically was worse in the paclitaxel-coated balloon group. So this resulted in us not using any paclitaxel-coated balloon in our BTK arteries in Singapore. And Casanos also went on to publish a meta-analysis looking at the risk of major amputation following application of paclitaxel-coated balloons for CRTI patients. And they concluded from this meta-analysis of about 21 RCTs involving nearly 4,000 lower limbs that the risk of major amputation was significantly higher for paclitaxel-coated balloons. Some trials did show positive paclitaxel-coated balloon results for BTK, and this was the DEBATE BTK and ECOART-2 BTK. The Lutonix BTK also said that theirs was a positive trial according to the authors, but for some reason, the FDA did not approve the use of Lutonix for BTK in the US. And we'll go on to look at why that was so. So this is the DEBATE BTK. It was a one-to-one randomization of about 132 patients, and they showed that 12 months binary restenosis was superior in the paclitaxel-coated balloon group compared to POBA. And there was also significantly better freedom from TLR in the PCB group. The ECOART-2 trial was a trial from China, and it showed that for BTK arteries, the use of their PCB also resulted in a superior result compared to POBA. 6 months primary patency was 75% compared to only 28% in the control group, and CTTLR was also better. The Lutonix group was a large trial of about 462 patients looking at composite primary effectiveness endpoint assessed at 12 months, which they define as freedom from major amputation, target vessel occlusion, and also CDTLR. And they reported that there was a 10.5% improvement over POBA when you use their paclitaxel-coated balloons in their primary effectiveness endpoint. So for all intents and purposes, they tried to report this as a positive trial. However, when this was looked at by the US FDA, this was unanimously voted against allowing the use of Lutonix paclitaxel-coated balloons for BTK in the US. So if you look at the timeline, the study was launched in 2013. However, they implemented statistical and endpoint changes in 2016. This was submitted to FDA. This was not approved, and they resubmitted to FDA, and again, this was not approved. I guess the main thing was that the FDA did not like the changes to the protocol. The primary effectiveness endpoint, for example, was changed from 12 months to 6 months. They added proximal segment as a co-primary endpoint, and they increased the sample size, and they adjusted for interim analysis. So I think for SFA, if you want to use PCBs, I would say that efficacy of paclitaxel in FEMPOP lesions is proven. There may be issues with mortality for claudicants according to the meta-analysis. However, this has been largely disproven. For BTK, what about the use of PCBs? The use of PCBs is less proven. It is equivocal, and there are lessons to be learned from the Impact Amphiron PCB. With the newer generation PCBs, there may be some use, but I would still say be careful. And in our own experience in the Singapore trial, we would definitely avoid the use of paclitaxel-coated balloon, particularly in our calcified BTK arteries. So I'd like to now go on to update you on the landscape of the use of sirolimus-coated balloons for both above the knee and below the knee. There are currently 2 sirolimus-coated balloons available in the market. You can use the Magic Touch, which I use a lot, and you can also use the solution SLR from Cordis. Other companies are also coming out with their own sirolimus-coated balloons, Somodix and also BD with the Prevision sirolimus-coated balloons, but these are much more early, and they haven't got their own regulatory approval for use in the market. So why Do I think sirolimus is the better drug compared to paclitaxel? The cardiologists have known this for a long time. This is a meta-analysis of the use of sirolimus devices for coronary artery disease published in JAMA more than 20 years ago. And in this meta-analysis, they showed that the use of sirolimus results in better angiographic restenosis rate, better target lesion revascularization rates in a population of nearly 4,000 patients. What are the biological possibility for the advantages of sirolimus over paclitaxel? Now, you've heard about earlier on in the earlier talk about, all the advantages, and I'm going to go through this again. Now, sirolimus, we know that can also inhibit SMC migration much more effectively than paclitaxel. And we know that SMC are the main causes of neointimal hyperplasia. Secondly, in addition, sirolimus also has anti-inflammatory properties. So I think this potentially can explain why sirolimus-coated balloons could be of much more benefit in below the knee arteries. And lastly, it has got no pro-apoptotic effects. It is cytostatic and it is not cytotoxic compared to paclitaxel. So what is the evidence for sirolimus-coated balloon trials for SFA? So I'll go through SFA evidence first. And these are the first in-human single-arm trials. The one in green, we've already got the results available. The one in yellow are the larger trials, which are still ongoing. And I'm pleased to say that I was the principal investigator for the Magic Charge trial, and we investigated the use of Magic Charge for SFA in the EXOC trial, and the results are available, and I'm going to go through this. So this was the earlier trial published by the German group looking at the solution first in human trial. And I want to focus your attention to the leftmost column, which is a sirolimus-coated balloon trial. And they looked at 6-month late lumen loss. The lower the late lumen loss, the better it is. And they were able to show that using this solution for SFA, the 6 months late lumen loss was very low for solution. This was 0.19 millimeters compared to 1.04 for POBA. And also compared to other trials using the paclitaxel-coated balloons for SFA, the 6 months late lumen loss for solution using the sirolimus-coated balloon was the best. In our own experience in the EXOC first in human trial, we showed that there was promising 6 months primary patency in the femoral popliteal segment. The 6 months primary patency was 88%. So how does this compare to our experience using paclitaxel-coated balloon? So you can see that the results are comparable. The sirolimus-coated balloon was 88% 6 months primary patency, and when we compare that to other data from the paclitaxel-coated balloon, namely the Ranger SFA and the Levant 2 trial, the 6 months primary patency for using sirolimus-coated balloon is almost the same as that using paclitaxel-coated balloons. So what about randomized control trial data for sirolimus-coated balloon? And I'm pleased to say that there is one trial using the Magic Charge called the Sirona trial, which was just recently made available only about 3 months ago. And this was the Sirona trial. The investigators in this trial recruited about 478 patients, and this was a head-to-head trial of sirolimus-coated balloon using Magic Charge versus paclitaxel. And they reported that in this world's first head-to-head comparison of sirolimus versus paclitaxel in fem-pop artery, that the primary patency of sirolimus drug-coated balloon was non-inferior to that of paclitaxel, 73.8% versus 75%. And in terms of CDTLR as well, there was no significant difference between sirolimus-coated balloon and paclitaxel-coated balloon. So what about sirolimus-coated balloon for below the knee arteries? And for me, this is the area of most interest because in Asia, we treat mostly CLTI and BTK arteries. And so far for BTK, the results are quite poor with just POBA alone. And we know that for PCB, this is not the solution because first of all, there's no benefit. And secondly, we're concerned about the high amputation rates. So what do we know so far about sirolimus-coated balloon for BTK? It is fair to say that we just have early data from small single-arm registries at the moment. These have shown promising results. I think it is better than POBA. However, there is not any RCT data available yet. So from our own EXOC trial, we published that the 6 months primary patency for below the knee was 74%. And this we felt very excited about because we know that we can only achieve much less primary patency using just POBA alone. In addition, there was also low requirements for repeated interventions at 12 months. TLR was high at 86%. Freedom from TLR was high at 86%. And then we showed excellent 12 months limb salvage success at 92%. So how did the sirolimus compare to paclitaxel-coated balloon? We know from our single Paclitaxel trial that you can only achieve 40% 6 months primary patency with paclitaxel-coated balloon, compared to a much better 74% in sirolimus-coated balloon. So for me, this was the most exciting part of the trial. And this was one of the patients from the trial, and this is she underwent the use of sirolimus-coated balloon for the proximal anterior tibial artery at 6 months. Achieved successful wound healing, and we scan her again at 6 months. The proximal anterior tibial artery, which had been treated, remained clean. At 12 months, there was some hemodynamically non-significant lesions. We consider this as patent. At 24 months, again, patent proximal anterior tibial artery, and I followed this patient up to 4 years, and even at 4 years, you can see that the proximal anterior tibial artery remained patent. We've also got real-world data because we've used a lot of sirolimus-coated balloon in our own institution. We looked at patients enrolled between 2018 and 2021, and we looked at 3-year clinical outcomes. We've got a total of 141 patients with magic touch sirolimus-coated balloon, and we compared that to patients who received only POBA. In 206 patients, we looked at freedom from TLR, freedom from amputation, amputation-free survival, and overall survival. And I'd like to draw your attention particularly to the 3-year freedom from TLR when we looked at SCB compared to POBA alone. And for us, the use of the magic touch sirolimus-coated balloon has profoundly impacted our practice, in that you can see from here the freedom from TLR, if you use sirolimus-coated balloon, was much more superior compared to the use of POBA alone. We can see that the graphs start to diverge at about the 6 months point, because we feel that at this point the sirolimus-coated balloon was able to act against neointimal hyperplasia, which usually starts to occur at about the 6 months period. And in terms of survival, there was also improved survival in our patients who received the sirolimus-coated balloon, 64% versus 55%, and we believe this is due to the frequently less target lesion revascularization in very high-risk population. So what are the ongoing SCB randomized control trials for BTK? There are multiple of these happening around the world at the moment. None of these are completed yet. However, I'm pleased to say that the largest one of this, SIRPRAT, has already completed their enrollment. So the results from this should be available in about 12 months' time. And I suspect that hopefully this will show a positive outcome for sirolimus-coated balloon, and then we can start using sirolimus-coated balloon for our BTK arteries. I'd like to draw your attention to the fact that sirolimus-coated balloon using Magic Touch BTK, even when applied to very distal arteries and the plantar arch, shows no distal embolization or slow flow phenomenon in my experience. This is one of the patients who had severe BTK arteries, and you can see how I applied POBA and applied this Magic Touch sirolimus-coated balloon all the way down to the plantar arch, and there was no slow flow phenomenon after application of the Magic Touch. In terms of the vascular community, you can see that already 3 years ago, 54%, the majority in Charing Cross poll, agreed that sirolimus is a better drug compared to paclitaxel. And when the poll was reconducted in 2023, again, the majority agreed that sirolimus is the answer to CLTI. So I'd like to just conclude by saying that for SFA, we know that paclitaxel is very effective. However, we've got very recent data to show that SCB is just as effective to PCB according to the Sirona trial. For BTK, PCB is equivocal and may even be harmful. SCB has shown promising data from single-arm studies. There is no distal embolization from the use of SCB for distal arteries, but we now await RCT data to confirm if SCB is superior to POBA. Thank you very much for your attention.